I want to thank the organizers for inviting me here, and it's been the past couple of years when we've done this, it's been a lot of fun. And I usually end up being the last person because diagnostics usually is the last thing you think of. No, I'm kidding. But it really is, it's fun to be here, and I think that diagnostics is probably the most ununderstood of any of the areas. I don't understand it sometimes, so I'm sure that others don't understand it either. Why are we talking about valley fever, coccidioidomycosis? That's because Arizona is the epicenter, is the highest concentration of cocci in the world as far as I'm concerned. And any trip between Phoenix and Tucson, you take your life into your own hands unless you've already had cocci. So, and you notice Texas is way down there in terms of actual rates. Sorry, I didn't show Mexico on this one, but next time we will have to show Mexico as well. I also show this slide over and over again, not from the standpoint about epidemiology, but to remember how difficult it is maybe to make or understand the serological response in cocci. For example, out of the 100 patients that we had, 60 have no symptoms. We have no idea what the immune response is in those patients in terms of antibody response. We do know that most of them probably would have positive skin test reactions, but we don't know as far as how many of them actually mount an IgM or IgG response and for how long. So it's very difficult to say when serologies are positive, when they're negative, when they mean anything clinically, and when they don't. And that's what you have to remember. Serologies are best for diagnosis of symptomatic real cocci. By real cocci, I mean somebody that comes in with invasive disease potentially, would be in those down here at the bottom, if I can see down here where patients disseminate. There it's fairly simple to make the diagnosis serologically unless the person is defunct as far as immune response is concerned, is not mounting an immune response. But otherwise it makes it very difficult. So remember all these different compartments that we might be dealing with some of these patients. You may see a patient comes in and has very minor symptoms. You do a serology, it's negative. Patient goes away, patient comes back, you do serology, still negative. That could be because it was cocci, but it was a very quick infectious disease and disappeared before he really mounted an immune response. Skin test would have been perfect in that setting. Before you do a skin test, it's negative. After the patient has a slight response, you do another skin test, it's positive usually. But not as far as actual serology is concerned. So when are serologies or any diagnostic test in cocci beneficial? Well, the sicker the patient, the more benefit you have, of course. Patient is asymptomatic. You really don't have to make the diagnosis. But there are other benefits for patients that come in and see you, say with what looks like community-acquired pneumonia. Perhaps we can avoid the use of bacterial antimicrobial agents. We all know right now we are trying to decrease the use of antibiotics, antimicrobial agents, because of all the potential side effects and resistance that we're seeing cropping up in our communities. Earlier identification of complication potentially, or decreased need for added extensive diagnostic studies. If we know what it is, we have a less tendency to do additional testing, additional evaluations. Sometimes it's much more difficult to make the diagnosis, like in this patient, which was a woman that came in with an abscess on her buttock. That's the only thing she presented with, an abscess on her buttock. And when they drained the abscess, they found it grew out coag-negative staph in small numbers. Now, being a microbiologist, I would say that's junk. That's nothing. That's skin contamination during collection. However, because you got that in a normally sterile abscess, many clinicians will say, that's causing the disease, and so that patient was put on cephalosporin. Was sent home, did okay, because the abscess had been drained. Well, patient came back in, and the abscess had reformed and became fluctuant. She was seen again, abscess drained once more. This time the specimen was submitted not only for routine culture, but for fungal culture. And that was the point that was made here. This time the pus was, no WBCs were seen, I'm sorry, there were a lot of WBCs, but no organisms were seen. And that should tell you something. If we see no organisms and lots of white cells, hey, there's an issue here. It's a fungus, it's something else. It's not routine bacteria. And certainly fungi grew out, and this one it was cocci. Serologies in this patient were positive. IgG weekly for IgM, that means it was kind of waning already. Patient had a recent history of infection, but was waning. The CF titer, complement fixation titer, was 1 to 16. Not too high, but it wasn't low either. So that was a pretty good case of cocci that was determined. One thing I think I need to tell you on this case, too, is serologies can go up and down. In this case, this was probably a case of disseminated cocci, which had localized. The patient actually was able to stop the cocci progression in the pulmonary region. But what happened, she was fungemic. A lot of these patients are fungemic, which then that fungemia disappears. But she remembers that prior to this infectious process, she actually had a bad case of coughing and pneumonia-like symptoms about 6 weeks prior to this abscess appearing. And during that time, she slipped and fell and had a hematoma on her buttock. So what happened, it was the fungemia landed in the hematoma. Now we have a petri plate, basically, in her buttock, which she wasn't able to take care of, and we had an abscess formation. So, cocci, very quickly here. Again, southwest area of the United States. The interesting theory is that it is a dimorphic fungus, but unlike histo or blasto, it really is not thermally dependent like histo and blasto. It really is more dependent on environmental location inside the body, in other words, not as far as temperature. You don't increase temperature and it becomes a mold-like item, or decrease the temperature, it becomes fungus again, a mold. So this is what the entity does. In the environment, it basically grows as a mold. It is very, very rapidly growing in the appropriate conditions. It cannot compete with other organisms. There was a question asked about agriculture. You take cocci and you put it into an area that has other bacteria and other fungi, and it'll disappear. So in a good agricultural situation, you don't see a lot of cocci in the soil, unless, of course, you don't grow anything and you're in say, Arizona, you haven't watered for a year, the other organisms die out, that's when cocci grows. It loves the summer heat because of its arthrochonidia, the spore that it has a very, very heavy outer coating which protects it from the sun. And when the sun beats down on the earth, the desert soil, it kills off most of the bacteria, allowing this organism to propagate very quickly as soon as it rains, because it has no competition at the upper portion of the soil. And then the winds come and disseminate the arthrochonidia, which become the actual infective entity here in most cases. And then it goes into the patient or the organism that's inhaling it. In the patient, it changes its format and it becomes a spherule with endospore formation inside the spherule. Once this spherule breaks open, each endospore can go on and then disseminate throughout the body. If the patient or anybody or anything dies or gets back into the environment, it switches very quickly back into mycelial form and does not grow as spherules or endospores. This is a picture of the actual arthrochonidia. You can see the arthrochonidia, very barrel-shaped, very heavy-walled, with what we call disjunctor cells, which are actually very weak. Any amount of air, and it disseminates. So it's perfect for dissemination. And here, this is one of the first haboobs that has ever been taken a picture of. I took this picture at home about 15 years ago, coming to our house. And you say, well, people don't like to be outside. Well, people are chasing their garbage cans all over the place, as you can see over here. And they just moved from Chicago, so they're one of those that are really prone to getting cocci. Initial diagnosis was mentioned today already. X-rays, and this is one of the little lesions that one sees, the nodule, and that's what happens probably most frequently in Arizona. I got this nodule about 6 months after I got to Arizona 33 years ago. That's myself. That's why it's a big-hearted person. Otherwise, it goes into cavity. So understanding what you're dealing with, you have a better idea of how to then approach it serologically or by culture. This is disseminated cocci with a lymph node infection. One point about this one, this is disseminated cocci. It likes, again, the extremities. But a lot of clinicians will look at that and say, boy, this looks like a bad bacterial infection, and we'll use a swab to culture it. What you get is garbage at that point. You might even get Staph aureus growing on there, but it's not what's causing the problem. Staph aureus doesn't cause problems just like that. So cleansing that, getting a biopsy of the advancing margin would be the way to do it. I like no swabs. If you don't use swabs for anything if you can't. Get away with it. This is a 27-year-old female veterinarian, or assistant veterinarian, who had a cat brought in by a Good Samaritan, found the cat kind of lost and wandering. Cat was very ill-looking. And while they were working on the cat bit this poor assistant on the hand. The cat died 4 days later. I would be very worried assistant at this point. The vet did well for about 12 days, and then the wound began to suppurate a little bit. And she really got sick in terms of the localized infection with a it actually went up progressively up towards the upper arm of that person. Serologies were negative. The serologies for cocci were negative. Biopsy performed on hand lesions submitted for diagnostic cultures, and guess what? We not only saw it in the calcifluor, but we also grew the organism out. Importantly, from this perspective, if you look at the serologies at the bottom, 3 months afterwards, they were still negative. So serologies may be negative, especially in some of these infectious processes, and you can't rely on them all the time. How do we approach then cocci? Well, hematologic, we talked a little bit about the SED rate, and yes, not many people know how to follow the SED rates or what they really mean, but anecdotally, the chairman of our department got really bad cocci, pulmonary cocci. Everything was negative on him until much later, about a month later, he had a positive serology, submitted to Dr. Papagiannis. Serology got better, he was not treated. So serology got better to about 1 to 2, and then actually it disappeared. But his SED rate kept on being positive. Nobody followed it. He followed it himself. He was a pathologist. And he followed himself for years. He kept saying, I just don't feel good. I just don't feel good. And the SED rate positive, the serology was negative in Dr. Papagiannis' lab. About 3 years later, he had cocci of his ankle. It was one of those, it had disseminated, it had lodged in the ankle, but it's almost impossible to follow this type of patients and see what's going to happen, as Dr. Ampel's data showed. As far as meningitis is concerned, I think that serologies are probably the most important component for making the diagnosis. Cultures of the spinal fluid are almost, not always, but almost invariably negative. So a serological diagnosis on CSF is very, very important. But otherwise, you can see the variations here. It doesn't really look like it's bacterial, and that can help you make a decision which direction to go. As far as actual diagnosis, then, we have direct microscopy. I love direct microscopy because it gives you the fastest information ever possible. If you have a biopsy and you see spherules, you've got the diagnosis. You don't need anything else. Culture doesn't really help you except if you want susceptibilities, and we never do susceptibilities anymore, or try not to do susceptibilities because we do not see resistance in cocci. So microscopic, either spherules or mycelial forms. PCR is available at Mayo Clinic. I'm not sure how good it is at this point. I don't know. According to the study we've seen, it's as good as culture potentially, but it is often also is not negative as well, especially where it really would be helpful would be the CSF, right? It's not very good in the CSF at this time. So I think it's still an ongoing process. We have to understand where PCR is going to land. As far as urine, BAL, for the galactomannan that Dr. Ampel had mentioned, Joe Wheat's laboratory in Mira Vista, very good test. Again, I'm not quite sure exactly where it sits. It may be helpful sometimes in a disseminated case. I think BALs may be even better than sera or urine, but we're just not quite sure where to go with that. Serologic testing is still the mainstay, probably, and it's the most difficult to understand. Skin testing, I think it would be great to have back because it really can help you in making a decision. It's the first test that goes positive. Skin test is the quickest and the most sensitive. Trouble is, it's not available at this point, except in Mexico. And culture, of course. And culture is not that bad. So what do we do? As far as specimens are concerned, depends on the patient presentation. We've got respiratory secretions, we get them. Sputum, for example, would be wonderful. Bronchoscopy, wash, or biopsy, bronchoalveolar lavage, or BALs. Normally sterile body sites also can be useful, like pleural, peritoneal, spinal fluid. Blood is not all that good. We have had positives, but it's like TB. It's so transient in the blood that it's very hard to pick it up. Like tuberculosis is transient, and you really can't do blood cultures unless you have an HIV patient, and that's a different story. So tissues, fine needle aspirates, biopsies, lung, open, brain, skin, all are very good as long as it actually goes to the site of the infectious process. For serologies, serum, spinal fluid, of course, is great. Synovial and pleural fluids are very controversial. We have experts that say they use them. Others say they're not very good at all because we get false positives. We don't know what to do with the data. So again, there's controversy in that respect. How about culture? We did a study quite a few years ago, we did a study for looking backwards at 6 years worth of data, 1,513 positive cultures. These are cultures now we got in our mycology department. Actually, right now, we grow about 350 positive cultures a year in our mycology department. These are cultures. Average days to recovery, 4.4. That's not really that bad. And as was mentioned we had the same as Dr. Ampel, 2 was about the fastest we could come up with. And primarily, I think it's because of recognition issues. They're so small that you don't see them on the plates. Calcifluor, which is a fluorescent test which actually stains the chitin of the outer wall of the organism. I think it's a great test. It's a very quick test that we can perform in the laboratory. We do it on all BALs, all tissues. We don't do it on sputum because the yield is much lower. But BALs and tissues we do. As you can see, it's about 22% of all culture positives we get. So it's 1/5. It gives you information much faster, within 2 to 4, 5 days faster than you would if you waited just for culture results. Types of specimens we get, I don't know if I think you can see that there. Respiratory tract for the same amount of time, get over 10,000 specimens. Non-sterile body side, 25. Look at the recovery rates on the right-hand side. You can see again, about 10% of specimens submitted were positive for cocci. Urinary tract, much less, of course. Non-sterile body size, probably abscesses, things like that, 2.5%. Bone marrow, 2.6%. And because people really thought that's where cocci was going in the sterile site. 0.9% for CNS and other normally sterile sites. So again, respiratory tract was the best. Direct microscopy, we can do KOH mounts, which now we use Calcifluor, which again is that fluorescent stain. Histopathology to me is really, if you got tissue, do a histopathology stain, because you can tell the reaction that you've got. You know what's going on. Even if you don't see spherules, you know what the reaction is, and it gives you an idea that it's cocci. So the pathologist can pick up on that. Several stains are good. The best one, I would think, is methenamine silver. It's the most sensitive of all the histopathologic stains. We use histopathology frequently. This is a gram stain, but don't go by this. It's one of the rare gram stains that actually stained this organism. That was because we had used KOH first. This is a spherule with endospores coming out of a sputum. This is a methenamine silver stain. You can see the endospores again. Importantly, this was a cavitary lesion. This is a better one, actually. You can see mycelial forms and spherules together. In a cavity, cocci forms, mycelial forms. And I got a lot of phone calls from outside Arizona. Well, they say, you know, we've got a fungus here. It's got mycelia. It's probably not cocci, right? And I said, wrong. It is cocci. It's the same thing, because in that setting, it does produce the mycelial forms. Here's some what look like almost arthrochondria and mycelial forms in the tissue surrounding the cavity. This is a Calcifluor of a spherule with endospores, just to show you what it looks like. And I'm going fast. This was a little harder. This was a specimen collected from a fine needle aspirate in lung tissue. And Cornell sent me this picture. I thought it was cocci, but boy, it sure looked weird. So you get weird things sometimes. It did turn out to be cocci, by the way. Nothing else grew. This was spinal fluid, and pathologists thought this was histoplasma. And he thought they were histoplasma yeast. When I looked at it, I didn't feel comfortable with that. Looked at the history, patient had not been out of Arizona. That was cocci-meningitis, and these were endospores. They didn't see the spherules, but they saw the endospores, and it turned out to be cocci. Cocci grows in almost anything. So getting a media is not the question. We've got positive cultures on routine blood media. The important thing to remember, it takes a minimum of 2 days, but it can take 4 to 5 or 6 days. Most cultures are only kept for 48 hours, 3 days. So most routine cultures will not pick up cocci. That's why you have to order fungal cultures, to make sure that you look for cocci and pick up those organisms. So the incubation time is what's really important, I think, in this term. So again, when you think of cocci cultures, ask for fungal cultures. Another thing, it loves Legionella media. And we do a lot of Legionella cultures, and we actually have picked up quite a bit of cocci on Legionella cultures. Funny, when we call the clinician and say, we've got cocci, he said, I didn't ask for fungal cultures. Sorry, we can take that back if you want to. It's most technologists in Arizona recognize cocci because they've seen it so many times. And early on, it's actually very difficult to tell. You can this is Legionella media up on top here, BCOA, and you can see a little light growth here. This is all garbage, but that's just a little white growth here. As it continues to grow, it becomes fluffy, and even fluffier here, and within 2 weeks, it's so fluffy, that plate would be opened up, you'd kill everybody in the lab, because you'd have millions of arthrochonidia flying in the lab. So we're very, very careful. Dr. Impel says, let us know when you think of cocci. Well, we don't wait for that. We consider every culture as possible cocci, because you don't know what you're dealing with either most of the time. We've actually had one bad exposure that we had to put the patient on therapy. It was a urine culture submitted to us from another lab for diagnostics, and it was sealed and everything. We thought it was sealed. She was taken to move it into a hood. The seal had broken. The plate flipped open right in front of her. I'm sure she was already, that's another reason for doing a skin test. It would have been nice to do a skin test on her immediately and see how she had cocci before, because we didn't know, we had to put her on therapy for a period of time, usually a couple of months. And fluconazole is not nice. They tell me that it's terrible, actually. Lab diagnosis, identification is quite easy. Microscopic morphology with spherules, that's cocci. So when we see histopathology is positive, we get growth. We don't go further to identify it. We say presumptive cocci because you already have the diagnosis. On the other hand, if we need to identify it, we go to, right now, all these other things are old. Mouse inoculations, converse media for conversion, and genetic probes are old. Trying to find that, oh, there it is. Genetic probes now being used to get the RNA of the organism and identify it as cocci. We can't separate Posadaceae from imidis, but we can call it cocci species. And that's all you really need right at this point. I'll finish up with the hardest part, and that's the serology. We've got IgG and IgM. IgM becomes measurable earlier on, but look at the time frame. It's the first week about 50% of patients, and third week about 90% of patients. So it's still a very variable amount of time. Somebody comes in with community-acquired pneumonias, usually in the first week of infection. You may have a negative serology at that point. The IgG, or what we also call the complement-fixing antibody, becomes measurable between the 2nd and 28th week. That's an awful long time frame. May remain positive for several months, but usually is related to disease activity. A lot of people also don't relate that IgG and IgM are indication of infection. They're not protective. So the higher the titer, especially by IgG, the more problematic the case is. The patient is actually having a great amount of activity of cocci. So it's not protective. It really does give you indication of the amount of disease the patient has, of what's happening. This is a good indication here. This is CMI, cell-mediated immunity. So as you have good cell-mediated immunity, you usually are able to localize the disease. As your cell-mediated immunity wanes or becomes poorer, that's when you start to actually enhance the the ability to disseminate the disease. Serum antibody over here, as that starts to increase, the better the chance you have of actually having dissemination of the. That's why we say follow titers. We're talking about complement-fixing titers or immunodiffusion titers that actually follow complement-fixing antibody, or IgG. This is an old picture here. As you can see, the first one, very first one here, the line is actually skin testing, and it's the first thing to turn positive. IgM is the second thing to turn positive, and then IgG comes up after that. So you kind of get a feel for how these serologies mount up and how they disappear again. So cell-mediated immunity, skin testing with spherulin, coccidioitin is no longer available, but may be available in the future, as mentioned. Humoral antibody indicates level of activity and is not in itself protective at all. Two precipitants were the old IgMs. Very few people do that anymore. Mostly we now use EIAs, IgM and IgGs, and immunodiffusions, IgM and IgGs, with complement fixation actually used to follow titers. Complement fixation should not be used as a diagnostic test by itself, okay, because it is the least sensitive of all of the other ones. But it can be very useful to follow titers, especially if done consecutively. Serology, humoral antibodies, I'm not going to talk too much here because I want to finish up quickly. EIAs, IgM, and IgGs, most sensitive, but that's a controversy. You heard earlier today, the state counts any IgM positive as being a positive infection. I'm not sure that's always correct. It could be somebody that's actually has a minor disease and becomes asymptomatic very quickly, and I'm not sure about that, but we've had a lot of patients with IgMs that did not seem to have cocci. Immunodiffusion, that's more specific because what you're getting is you're getting a line of identity. What happens is we put the, I'll use this side here, the antigen is put in the middle and the patients here are put in the outside wells with diffusion going on. So well 1 and 4 are normally the controls with known positive cases, and then the patients go into wells 2, 3, 6, and 5. You can see 2 and 3 are negative, there's no line, whereas 5 and 6 not only have a line, but the line connect with the lines from the known positive patients. That's called a line of identity. Sometimes you see lines but they don't meet with the other line. Those are lines of non-identity. We cannot call those as positives. Complement fixation test also is useful, as I mentioned, and not most labs, but some labs perform that. They're very useful to follow titers, especially if you got somebody that's progressively getting worse or is not doing well. And that's when you would use that component. Quickly, EIA IgGs. In one study, this was looking only at positive, culture-positive sera. EIA was most positive, was most sensitive with 79%, EIA IgM was 63%, EIA combined 83%, ID 71, and CF 64. What this study did not do is look at the false positives. They did not look at culture negatives and see how many of those has positive serology. So this is just looking at positive cultures. The study we did very quickly because we wanted to use EIAs as a screening test. And the reason we want to do that is we can do that one day. If it's negative, it goes out the door. If it's positive, however, then we would set up immunodiffusions to see whether or not we would get the line of identity. If we were to do immunodiffusions alone, a negative immunodiffusion takes 5 days. You have to wait that long to call it negative. A positive can become positive faster, but a negative has to wait for at least 4 to 5 days, depending on what kit you're using. So we used this test here, and we found 50 patients. All of them were negative by EIAs. They were all negative by immunodiffusion. So we felt comfortable using the EIAs, a rapid screening test, getting it out of the door. Dr. Blair did a study where she found 405 patients. There were no false positive IgMs in her study, so they felt very strongly that IgMs were very, very specific. Dr. Kubersky, on the other hand, did the same thing. He did 17 patients, and he followed these patients both clinically as well as by looking at their charts. And what they found was that when the IgM was positive alone, they had a very high rate of what they felt was false positives. When both IgG and IgM were positive, they had only 20% false positives, they felt. So when you see an IgG, IgM, EIA, both positive, you have a much better chance of that patient really having significant, he might have cocci, but maybe an insignificant cocci, but significant cocci. This is just another presentation. I'm not going to spend much time here of his patients that he followed up. And this was actually retested by a referee lab, and the referee lab was Dr. Papagiannis' lab, which could not confirm the IgM, IgG at that point. So problems with serological diagnosis. First of all, serologies are always prone to false positives and false negatives. You know, the one thing I want you to understand is serologies are not perfect. Especially early on and later on. And so they should not be used alone as an indication of anything except as you have to look at your patient, look at the clinical circumstances, and then use that serology to confirm or refute your clinical decision making. There's lab-to-lab variability. There's lot-to-lot variability. There's discrepancy between test systems, reagents, and automation. So all of these things play a role. So I feel very uncomfortable saying one serology is positive. We had a patient with hepatitis, for example, or was diagnosed with hepatitis because the IgM was positive. Not once, repeatedly positive. And so that poor patient was told that she had hepatitis. There's a small percent of patients that have biological false positive IgMs who do not have hepatitis. So you have to understand the background of these things when you make your decisions on some of these patients. Also, understand what your laboratory is offering, because different labs will offer different things. For example, Sonora Quest Laboratories, and I'm in charge of that micro department, we offer coccidioidomycosis screens, which includes the EIA screen for IgM and IgG, and then I felt important that we also add the immunodiffusion test to see whether or not that would support that. Then the physician makes up their minds whether or not they should follow up. Patient gets better, you might forget it. Patient's getting worse, you do additional testing. You can reflex the titer. Patient's pretty sick, you can do the screen. If that screen is positive, then you do a comp fixed titer because the patient's very ill and you're going to follow that titer over a period of time. You can do the comp fixed titer by itself if you're following a patient, say, over a period of 6 months to a year, and you want to follow the titer, so you can order that by itself. And one thing that Dr. Papagiannis and I feel strongly about, you can actually order the CF titer and ask the lab to hold it for several months, because then when you do a follow-up titer, you really want both done together. There's variability between 1 and 2 days. For example, I follow my dog who has disseminated cocci with comp fixed titers, and started 1 to 128. 6 months later, we repeated the test and was 1 to 64. But the first one was 1 to 64 also. So my dog was not retreating in their titers, which would look like they might be if you only did individual tests by themselves. So you've got to understand, serology is a plus minus one usually. So you can't really follow titers unless you have a previous, especially if you switched labs. That's the worst thing you can do. Switch from one lab to another, you'll get totally different results potentially. And Coxi, Coxi as a whole, the isolate, is a select agent. It's considered a bioterrorism agent and can't be made into a weapon. So we have to treat it totally different than we do any other organism. We cannot hold on to Coxi, for example, for more than 7 days. So we can't keep an organism. We have to destroy it. We have to report everything to the CDC. We have to tell them how many plates we've destroyed, where they came from, who the patient was. All that information has to go to the Centers for Disease Control. We're hoping that as we speak, they're going to take Coxi off the select agent form because that will make life easier for everybody. I'll be able to do studies again, which I can't do right now very easily. And if you want more Coxi, you can go to the Coxi market, both in Italy and in France, and hopefully we'll start Coxi markets here in California, in Arizona as well. Thank you very much.